We'll have a question and answer period after the presentation, and today you'll hear from our executive director, who's with me today, Dr. Robert Walley. Our previous session focused on the history of MaterCare International and its formation, but today we're focusing on MaterCare's currently running project, Isiolo. We're excited to share with you an introduction to that region in Kenya, some of the challenges of working there, and how those challenges continue to be overcome. Join us for the question and answer period, and please be aware that we are recording this presentation to share online. Dr. Walley?
Thank you. Hi, everybody. Thanks very much for your interest in MaterCare and the project that we have in Isiolo. The project has come through a sort of development from when I first started developing ideas about how you can provide comprehensive obstetrical care to mothers who in particular live in rural areas. And that's been going since, the mid-80s in Nigeria, and then in Ghana, and also a number of other countries. But MaterCare became involved in Kenya in March of 2005. And it's because of the gentleman you see on the right, because that's me on the left. And the gentleman on the right is the late Bishop of Isiolo. His name was Bishop Luigi Locati, an Italian who'd been working as a missionary in Isiolo for 44 years when I met him, 9 of which was bishop. And I was on my way to Rwanda, and suddenly one morning here in the office, I get this email that says, "Would you come to my diocese and tell me what to do about maternal health care?" So we get a lot of funny kind of emails at times. So I kind of checked to see who he was, and there he was, legitimate Bishop Locati. So I sent him back a message and saying, "Bishop, I'm terribly sorry. I'm on my way to Rwanda, but maybe I can come some other time." He's kind of a persuasive sort of guy, and he sort of said to me, "Well, if you want to go to Rwanda, you've got to go through Nairobi. You can come here." So I went there and basically found nothing. And that's how we've come to develop it. Just something about Bishop Locati. He was a doer. He got on with doing things, always traveling around in this whole area, vast area of Isiolo. And we talked together after I'd seen it, and I explained what I thought we should do as an obstetrician is provide a project to provide essential obstetrics. And he said, "Yeah, that's a good idea. Let's start working on it." So I started working on it. And 3 months later, I got the message that he'd been murdered outside of his house by people who objected to what he was doing. In fact, what he'd found was that was corruption, and he'd stopped it. So that it all started on a tragedy, but it's his legacy that we've now come to. Just so you know where Isiolo is, you can see a small map on the right-hand side showing Kenya, right over on the east coast of Africa. Then you can see Canada, and Isiolo is more or less bullseye, plonk in the middle of Kenya. It is right under Mount Kenya, you see it, and on this particular day, you can see the snow on the side there. So we have snow to deal with, as well as very dry heat and very arid conditions. This is looking down onto the valley, which is enormous, part of the Rift Valley system, which goes all the way up to Ethiopia, South Sudan. The top on your right, you have Somalia, on the left, Uganda. So what we've always tried to do with this project is to look where the deaths occur and where the mothers who die live, and that's in their villages. Rather than sort of have a hospital and then sort of say, "Okay, everybody, just get to the hospital and we'll sort you out," we thought we should start with where the mothers are delivering. And this is a little bit busy, these pictures, but at the top you'll see the village and the sort of conditions they're delivering in. And you can see the small manyata, they're called. They're little huts which are movable because they're all pastoral people, mostly of the Samburu, Turkana, and Borana tribes. And what we did, first of all, was to start training the traditional birth attendants to do a number of things. First of all, we told them, check that they knew and had the equipment to do safe, clean deliveries. Usually in the compound or in the house where the mother usually delivered by herself. If she was lucky, she would have a relative, but often she would have a traditional birth attendant. And these are ladies who are, but they are experienced. They know the good and the bad, and they want to help. And we started to train them. At the same time, the government was saying, well, we want everybody to deliver with trained staff in a proper maternity clinic. But the problem with Isiolo County, which has a population of 188,000, it has one general hospital, one operating room, and one delivery room. And the problem is that most of these times they don't function. So we were doing the right thing, is going out there and looking at training the TBAs, do a safe, clean delivery, and then training them to learn how to identify and then refer mothers who may be at high risk of having a life-threatening complication to the hospital. And so that required a number of things. First of all, I have to jump to the bottom. We did have to have a hospital where you can deal with life-threatening situations like providing cesarean section, blood transfusion, and so on. But at the same time, we carried on and started to build one of the first parish maternity centres. That one was the furthest away. It's 225 kilometres away over a very difficult terrain, which you'll see in a minute. But one of the other things, so the midwives who were in practice up there, the trained midwives who were practicing up there, usually out of their homes, so they could get round, we provided them with a little motorbike ambulance, which it's like a mountain bike with a stretcher on the side where the patient or the mother can sit or lie. On the back, there's a pillion where the midwife can sit. And then there's a box, there's an IV pole, and it carries water and you can carry blood. So that allowed them just to go round and round the villages, preaching the gospel of the need for prenatal care, and then to try and get to a place where there is a safe, clean place to deliver. And so we got on and built the one maternity centre, as you can see there. It's just a model there, I'll show you it in the middle. And the next thing was to provide an emergency transport system. That idea first began in Scotland way back in 1940 when there was awful maternal mortality. And they knew that you can't expect somebody who's bleeding or who's in obstructed labor to try and get to the hospital. So you tried to take the hospital to where the mother is. So they had what they called a flying squad, which is an ambulance like that, which is staffed by a doctor, a senior midwife, and over there at that time was an anaesthetist, and all the equipment, including blood, that you would need even to do a cesarean section in the bed. But most of the time, it was to resuscitate the mother and then get her back to the hospital as quickly as possible and as safely as possible. So we introduced that. And then the other thing, as you can see, not so clearly, I don't think, at the bottom, is Manyata. The idea is if you can identify mothers early who may have a complication, or indeed if a mother lives too far away from the maternity center, she can come and stay and live in the hospital, or in this case, the maternity clinic compound. And there usually they can look after themselves because it's a strange phenomenon. You could have a potentially life-threatening obstetrical condition, but you feel fine, however, until you go into labor. So it's called a manyata, and we built our own version so they can live comfortably, and then they can have relatives to look after them. And then, as you see on the left-hand side, we built a maternity center at the hospital. We named it eventually after, because he was alive at the time, and we were the first to name an institute, any institute, anywhere in the world, St. John Paul II Maternity Hospital, because he was one of the people who encouraged us to set MaterCare up in the first place, going right back into 2001. So I don't know whether you can see that very well. I can't see it too well. What really is necessary is to provide essential obstetrics. And you'll see the title here, 91% solution. If you look at the WHO statistics on maternal deaths, you will see that the most common is postpartum hemorrhage, and then high blood pressure, hypertension, and then indirect causes of HIV and anemia, which is very severe, and malaria and so on. And then other causes and so on, and infection in particular. And if you total that, that's 91% of the deaths. And those deaths occur in the last 3 months of pregnancy, during labor and delivery, and a week after. So obviously nothing else is going to be much use if you want to reduce maternal mortality and morbidity, but provide essential obstetrics. And we call that the 91% solution. And what is that, essential obstetrics? Well, it's for the normal delivery of the normal mother to deliver in a safe, clean place, a maternity clinic, with a trained midwife, with access to transport and with access to communications and so on. And then in addition, the transport that you might need if things go badly wrong. Now, below you'll see 9% is from abortion, and that may be spontaneous or induced, a very low number. So we provide the 91% solution. And this is where we started with a maternity clinic, the first maternity clinic. On the left, what you see there is a very old dispensary, which still functions. We had to keep shoring it up because it kept on falling down. But on the right-hand side, we've built a maternity center in a place called MaterCare, 225 kilometers from Isiolo, where the base hospital is. The maternity center has 4 beds. It has a delivery room, and it also has the capability of doing a cesarean section. So we've got a little operating room, and it has a lab, a small one, and a pharmacy. So as many of the mothers as possible are invited to come there for prenatal care throughout pregnancy, at least 4 times, if not more, if they're in there, but then for the delivery. And that's where we put that maniata. You can't see it, it's the back of that ambulance, you see. And then they can wait for the delivery from the midwife. Now, that maternity center, because everything in Kenya now is connected by cell phone, there are no landlines, and the cell phones work very well. So the midwife can get in touch with the base hospital anytime, the day or night, by cell phone, ask for advice or ask for transportation and so on. So that's MaterCare. And there's the ambulance, and it's fully equipped to go to her, but we don't call it a flying squad, we call it an emergency transport. There's the motorbike ambulance, and there's one of the drivers of that. None of these things are designed to go fast because, as you see, the conditions they travel over are not very good. So you can see this is what we have to drive with 225 kilometers. And the problem also is one of security, because you're getting very close, about 200 kilometers from the Somali border. And then there are armed robbers and so on. And we've been shot at once. Fortunately, the bullet that we were trying to kill the driver hit the wing mirror and bounced off. But we do have paramilitary escorts when we go up there. But sometimes at night that's not possible. So the driver and the midwife travel alone, and it takes about 4.5 hours to get to Roti and then to travel back. And so you can at least bring the mother safely and comfortably back to the hospital. One of the things we did, first of all, was to train the traditional birth attendants. And it's interesting, the people who are in this area of Murti are all Barana, but they have Christian Barana and Muslim Barana. And when they come together, because they live separately with the police post separating the Muslims from the Christians, they all come together. As the lady you might see at the back there remarks, you can see her with a veil in black, she remarked, you know, when we are all together, we are one. And that's kind of convinced us that it's the women, it's the mothers who are going to solve any ethnic or religious problems just because they all have the same needs of love for babies and mothers and babies. You'll see two people there. In the center is the new bishop. His name is Bishop Makobo, and he's in. My colleague on the left is a Polish professor of obstetrics who comes over and helps as well, and that's me down there on the floor. And if you could see this, I just wanted to explain how we can possibly teach these illiterate but experienced, they're not unintelligent, but they're not educated, TBAs, on how to help identify high-risk mothers. So on the right-hand side, rather graphically, but these are little pictures of the most common complications of pregnancy that may lead to death. Like at the top there, you can see a mother lying back, and you can see a little diagram at the top there showing black and white and black. That means 24 hours you shouldn't have be in labor. And then various hemorrhages occurring before and after delivery. And then things like the convulsions of pregnancy and short stature. And when you've had previous obstetric surgery, like a cesarean section or some physiotomy, or you have a breech or something of that kind. So if any of these are identified in a previous pregnancy or this one, then they're sent to the hospital. And down at the bottom, you can see something called great confusion at the beginning, because they wondered what a school teacher with a classroom of kids was about. And it's supposed to be what we call grand multiparity. That means a mother with at least 5 children. So we had to edit this section. And then over on the left-hand side, we want to know something about the pregnancy. And these mothers and the TBAs are illiterate, but they're numeric. They can count because they use money. So they drew little diagrams, and they chose all these things on the right-hand side. So you can see at the top are little matchstick people indicating the number of live births that they have at home, the number of children they have at home. Then underneath that, the number of dead babies they've had. And then to the right of that, the number of miscarriages. So then underneath that, you can see the moons of pregnancy. So immediately you can get some idea about this lady, this mother, and her obstetrical experience and when she is due. And that becomes really important in how you're going to manage. And then at the top, we want to know what's going on in that area. And you'll see 4 little diagrams here of the outcome of a pregnancy when you have a live, healthy mother and baby, where you have a live mother, a dead baby, which is quite not uncommon, unfortunately. And then you have a live baby but a dead mother, and then both are dead. So when you have these, you're getting, we keep the records, an idea of the public health situation, obstetric public health situation in your area. And I forgot to mention that the maternal mortality in Isiolo County, 188,000, is anywhere from 450 per 100,000 where in Canada it'd be one or two per 100,000. But the epidemiologist who told us what he thought the figures were, he said there's a huge amount of underreporting. Excuse me. And he thought it was more in the region of over 750 per 100,000. So it's one of the highest rates of maternal mortality. It's certainly in Kenya, but in East Africa. And then just at the top here, we ask if a mother goes into labor early, that she comes to the hospital anyway because she's having premature delivery. And there you'll see a proud lady standing in the center. She's a TBA, and she has just delivered the baby on the right. Now, we're discouraging deliveries in the Manyata for obvious reasons, and we're trying to get the TBAs to make sure that all the mothers they see in the villages come to the hospital for prenatal care and delivery. And you can see the condition in these Manyatas. And you can imagine being in there, even if it's a normal delivery, alone. Or you can imagine if you're with a severe postpartum hemorrhage, it must be absolutely terrifying. Or you've got obstructed labor and you have no way of getting to any sort of help. And that can go on for days. And then, of course, you go unconscious when you're having a convulsion because of high blood pressure, eclampsia. So we wanted to make something different. Why shouldn't mothers in poor areas of Africa, like Isiolo, which is one of the most neglected areas by everybody, by their own governments, but indeed by NGOs, because a lot of people don't want to go up there because of the security problem that exists. But just remember, if there's a security problem, not only does the mother have to deal with all of those things, and you can imagine in refugee camps all over the world these days, how the mother has to deliver with bombs and machetes and all the cruelty that's going on. And on top of that, all the obstetrical complications as well. So this is the hospital that we have built. And it's nice. There is no other hospital, I don't think, in the country that is so nice. That's the entrance area. And where there's a waiting room area. And there we have a delivery room, a normal delivery room. It's clean, it's safe, it's optimistic, it's bright. And there we have a delivery table, and on the right, there is a baby table where you can keep it warm, even in the conditions there after delivery, and do whatever has to be to resuscitate a newborn. And these were donated to us from Poland. They are incubators, of course, and they've done well with these because they've had the babies survive. They're very small, and the nurses there have looked after them for 3-4 months until they're able to go home. So we can reduce the perinatal mortality. And there's one of the operating rooms. We have two, one for doing cesarean section and the other one for doing unclean cases. And here we are, there's a mother comes in. She's scared, some relatives are scared, there's an emergency. And there's the outcome. One of the first babies, well, I think the first baby delivered. I forget his name, a strange kind of name for Africa, something like Cyril or something like that, I think, I can't remember. And then there's the happy mum. That's what it's all about. So this is all of what Project Isiolo is about. It's a demonstration project that is nothing new in terms of the individual things we've brought together. But the difference is we put a comprehensive system together. So it deals with the obstetrical needs, it deals with the problems of staffing, it deals with the problem of transportation and so on. Unfortunately, we get no government funding. In particular here in Canada, we have been turned down just recently, a week ago, for the 10th time. Even though the government of Canada invited me to go and brief the Prime Minister's senior policy advisor. And then they invited me to a high summit on maternal mortality that was held in Toronto, which was only about all the great and the good and the wealthy and the queens and heads of state and all the rest of it, all telling each other how wonderful they were. But not one of us who are obstetricians or midwives were able to say that, you know, if you're going to reduce maternal mortality, you're going to have to do it one mother at a time, and you're not going to need me or a midwife. Not me, a doctor trained and a midwife, not a person with a checkbook or a political philosophy. So there we are. I hope that's giving you some idea of what we're about.
Thank you very much, Dr. Walley. I'm going to open the floor now for some questions.
All attendees are muted and may unmute themselves by pressing *6.
So people can unmute themselves to ask questions, or they can type a question here into the chat window, and I'll relay that to Dr. Walley. And Dr. White, I had a question while you were presenting the moons of pregnancy. Do the women document that themselves, and so they're aware of?
Yeah, that's how they do it. The moons of pregnancy, okay. And as I said, they can count, so they can make the number of marks. So exactly. When they showed you that thing, the TBA will make a mark on the number of dead babies, live babies, or on the moons of pregnancy when she's being seen, and so.
Right.
And
so
what we do.
Pregnancy.
Pardon?
So the moon is a month, 1 month of pregnancy.
Yeah, a month, yeah. And what we do is the TBAs are asked to fill in a form for each mother they see, and then the midwife will check each one herself when she might see the patient. So it's sort of a continuity. We're not there to put the TBAs out of work, but we're there to get the whole of a continuity from the village to the hospital as necessary.
Right. And for the other attendees, if you're having problems unmuting yourself, you can just hit *6 there on your keyboard and ask away. And you should also be able to just click on your little microphone there and start speaking.
I'll tell you what I want. If there's anybody who's been watching and listening to this, we need your help too. We need to show what we've been doing. You can tell others, or you can join and help us. That would be really useful.
And we have a question here from Emily from Yorkshire. She was saying, are the midwives and doctors that actually work at the hospital, are they volunteers or are they local?
No, they're all local. The hospital is run by 4-5 sisters who are from a order that runs hospitals here in Toronto. It's a big organization. Their sisters run the hospital, and then we have trained Kenyan midwives, and we have locum doctors. One of the difficulties, however, is getting staff up there, because nobody seems to want to go out of the big cities, and most people say Isiolo is a dangerous place. It's not. It's going to be a very important second capital of Kenya. But we are going to be looking for midwives, especially those who would like to go and if they can, if they want to teach things like infant resuscitation and so on, and then put procedures that they've used in their own hospitals. Most of the midwives over there are well trained to a certain extent, but we are living and working in tough areas and difficult areas. So right now we didn't have the funds to send anybody over there, but we're looking at both volunteer midwives and volunteer obstetricians who want to go.
So we're looking for volunteer midwives and obstetricians, not from Kenya, but that are willing to go.
From anywhere, yeah. I just wanted to add one other thing. The whole concept of this is to have a sort of a specialized center for all of women's health related to obstetrics. And the added part we will add is a fistula hospital, specialized fistula hospital. As you know, some mothers get obstructed labor, damage to the rectum and the bladder, or both, and they become incontinent and they need to be repaired. And they need to be treated as well as rehabilitated because they suffer a lot.
There's just a follow-up question there to the volunteering. It says, how much experience do you need to go and volunteer?
Well, some experience. If you volunteered, you'd have to go for at least 3 months and speak English, because that's the working language. You'd have to have some experience as a midwife, both maybe community, but also in hospital situation, and be comfortable with deliveries. I mean, if somebody volunteers, they could go to work in the rural clinic, but we would think about that before we did that, but certainly in the hospital. So some experience is necessary.
All right, and before we conclude, are there any final questions before we end here? I'd just like to thank you all again for coming today. We will be having more webinars in the future, and you can find all of those on our website or by joining our mailing list. And I want to thank Dr. Walley for this presentation. It was educational for me as well, and I've been working for MaterCare for a few years now. Thank you, and if anyone has any questions, you can email them directly to us at info@matercare.org, and I'll just type that email out for everyone.
I just wanted to add my thanks to you who are out there. I don't know how many are out there or where you're from, but anyway, wherever, you could tell other people what we're doing and introduce them to the website and so on. That we are a bit unique in that we are trying to do something that nobody else has tried, a demonstration project, a comprehensive rural obstetrics. Thank you very much.
Thank you. God bless everyone.
Bye-bye.